Today we are going to discuss anemia. There is no need to write. I will put the link in the description. You can also download this lecture. So, what is anemia? Anemia is decrease in the red cell count or hematocrit, which leading to decrease in the hemoglobin concentration according to the person age and the sex, which result in decreased oxygen carrying capacity of blood. We classify anemia on basis of its etiology and morphology. This classification is based on its morphology. So morphologically, we classify anemia on the basis of MCV and MCHC. On the basis of the MCV, we classify into microcytic anemia, normocytic anemia, and macrocytic anemia. And on the basis of MCHC, we classify into hypochromic anemia, normochromic anemia, and hyperchromic anemia. So this classification is based on the MCV. First type is the microcytic anemia, in which MCV is less than 80 femtoliter. And which type of diseases causing this type of anemia? These are the iron deficiency anemia, thalassemia, anemia of chronic disease, and sideroblastic anemia. Second type is the macrocytic anemia, in which MCV is greater than 100 femtoliter. And which type of disease is causing this type of anemia? These are the megaloblastic anemia, which is due to the vitamin B12 deficiency and folic acid deficiency, alcoholic liver disease, hypothyroidism, and myelodysplastic syndrome. Third type is the normocytic anemia, in which MCV is the normal between 80 to 100 femtoliter. It is further divided into two types: normocytic with low corrected reticulocyte count and normocytic anemia with high corrected reticulocyte count. Normocytic anemia with low corrected reticulocyte count, in which reticulocyte count is less than 2%, and it is usually seen in when there is blood loss history less than 1 week, aplastic anemia, renal failure, early stage of iron deficiency anemia, and early stage of anemia of chronic disease. Second type is the normocytic anemia with high corrected reticulocyte count, in which reticulocyte count is greater than 2%. It is further divided into two types: due to intrinsic RBCs defect and due to extrinsic RBCs defect. Normocytic anemia with intrinsic RBCs defect, which is seen in sickle cell anemia, G6PD deficiency anemia, hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, and extrinsic RBCs defect, which is usually seen in when there is blood loss history greater than 1 week, hemolytic anemias, microangiopathic hemolytic anemia, and malaria. So before going into deep into each type of the anemia, first we are going to discuss RBC's index. First is the hemoglobin. In the man, its normal range is 13.6 to 17.2 gram per deciliter, and in the woman it is 12 to 15 gram per deciliter. Then is the red cell count. In the man, its normal range is 4.3 to 5.9 10 is power 12 per liter, and in the woman it is 3.5 to 5 10 is power 12 per liter. Then is the mean corpuscular volume, MCV, which is the average volume of the red blood cell. When the volume of the red blood cell is small, we call macrocytic red blood cell, and when volume is large, we call macrocytic red blood cells. And its formula is hematocrit divided by red blood cell count multiplied by 10, and its normal range is 82 to 96 cubic micrometer or femtoliter. Then is the mean corpuscular hemoglobin, MCH, which is the average mass of hemoglobin per red blood cell. Consider this is the red blood cell and this is the hemoglobin. So MCH is this average mass of hemoglobin per red blood cell. Its formula is MCH is equal to hemoglobin divided by RBC count and multiplied by 10, and its normal range is 27 to 33 picogram. So then is the mean corpuscular hemoglobin concentration, MCHC, which is the average hemoglobin concentration in the unit volume of red blood cells, and its formula is MCHC is equal to hemoglobin divided by hematocrit multiplied by 100, and its normal range is 33 to 37 gram per deciliter. Remember, MCH is the average mass of hemoglobin, but this is the average hemoglobin concentration. Then is the red cell distribution width, which show the variation in size of the red blood cells in the peripheral blood smear, which usually measure the degree of anisocytosis, and normal it is 11.5% to 14.5%. Then is the variation in the RBCs on the peripheral blood smear. First is the anisocytosis, which is the variation in size of the red blood cells, which is usually seen in the megaloblastic anemia and in the thalassemia. Then is the picarocytosis, which is the variation in the shape of the red blood cells, which is usually seen in the myelofibrosis and in the thalassemia. Then is the acanthocyte. These are the spicules on the red blood cells, which usually seen in the splenectomy and A beta lipoproteinemia. And then are the Burr cells, which are also spicules on the red blood cells, but less marked than the acanthocytes, and usually seen in the renal failure and in the liver failure. Then are the schistocytes. These are the fragmented red blood cells, which is usually seen in the macroangiopathic hemolytic anemia, DIC, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. Then is the dimorphic picture, in which we found both types of red blood cells, small and large, which are usually seen in the sideroblastic anemia after treatment of iron deficiency anemia and vitamin B12 and folate deficiency anemia. Then is the Rolex formation, in which RBCs tags on each other due to raised ESR, which is usually seen in the multiple myeloma, paraproteinemia, and in chronic inflammation. Then is the basophilic stippling. These are the denatured products of RNA which found in the red blood cells and which are usually seen in lead poisoning, reticulocytosis, and liver disease. Then are the Byte cells and Hinge bodies. These are the characteristic cell of glucose 6-phosphate dehydrogenase deficiency. Then are the reticulocytes. These are the larger spherical red blood cells with bluish color due to free ribosomal RNA. They usually enter in the circulation, and after 1 day they convert it into mature form of the red blood cell. They are the marker of effective erythropoiesis. So we are going to discuss microcytic anemia and its first type, iron deficiency anemia. First, we are going to discuss sources, absorption, storage of the iron and its metabolism. So total body iron mass is 2.5 gram for women and 3.5 gram for men. 80% of this mass is present in the hemoglobin, and 20% of this mass is present in the enzyme, macrophages, and in the liver. Red meat, liver, bread, eggs, green vegetables are the sources of iron, and iron in the green vegetables is present in the form of the ferric. 20% of iron we get from the heme source, which come from the red meat and the liver, and 1 to 2% we get from the non-heme source, which come from the plant source. Then is the absorption. Iron is released from its complex, and it is first reduced to the ferrous form by the action of gastrin and HCl. Oxidized form must be converted into reduced form for its absorption. Iron absorption usually takes place in the duodenum and in the jejunum, and its absorption is totally under the regulatory control. Then it is storage. Iron is stored mainly in the liver, in the reticuloendothelial system, in the form of hemosiderin and ferritin. Hemosiderin is the major storage form of the iron, but it releases iron slowly. Ferritin is the primary storage of the iron, and it releases iron when there is a need. Iron is also present in the macrophages, which come from the breakdown of the red blood cells. Transferrin, it is a protein which transports the iron from the plasma to the erythroblast and to the liver, and avotransferrin is the transferrin without iron. So iron metabolism at the normal condition, we getting iron in the form of heme iron and non-heme iron. Heme iron enter in the enterocytes through the heme transporter, and non-heme iron first it convert into Fe3 plus form to Fe2 plus form and enter in the enterocytes through DMT1 channels. In the enterocyte, it may be stored and lost during the shedding of the epithelium, and may be enter into the circulation. It enter into the circulation through the ferroportin channels, and first it convert into Fe2 plus form to Fe3 plus form, because this form is transported form in the plasma. Plasma transferrin transport it into the bone marrow and to the liver, and liver also produce the protein hepcidin, and this hepcidin is the negative regulator of iron absorption and its transport. So what happens when there is a low plasma iron? Liver start to decrease the synthesis of the hepcidin, and there is increased absorption and transport of the iron. But when there is a high plasma iron, liver start to increase the synthesis of hepcidin. This hepcidin block the ferroportin channels, and there is decreased the absorption and transport of the iron. 1 to 2 milligram of the iron is daily absorbed, and 1 to 2 milligram of the iron is daily lost by the shedding of the mucosa and epithelial cells. Plasma iron is 4 milligram, and 20 milligram iron is daily transported to the bone marrow for the production of the red blood cell, and erythrocyte iron is 2500 milligram, and same amount 20 milligram is daily released in the plasma by the breakdown of the red blood cell. Body store 1000 milligram of the iron in form of the ferritin, and iron in the myoglobin and respiratory enzyme is 300 milligram. So factors which affecting the iron absorptions. First, factors which enhancing the iron absorption. These are the pregnancy, iron deficiency anemia, increased erythropoiesis, and vitamin C. And then a factor which decrease iron absorption. These are the excessive phosphate, phytate, and calcium in the diet, iron overload, hemochromatosis, decrease erythropoiesis, malabsorption syndrome, and decrease HCl. So what is etiology of iron deficiency anemia? First, there is insufficient intake. Maybe there is decreased intake, or there is any eating disorder like pica, anorexia, bulimia, self-imposed dietary restrictions, and food insecurity. Second cause is the decreased absorption due to the celiac disease, due to inflammatory bowel disease, due to surgical resection of gastrointestinal tract, or there is excessive dietary calcium and oxalates. Third cause is the increased demand. Increased demand may be due to pregnancy and lactation, and may be due to growth of infants and the children. And fourth cause is the increased loss, which is the most important cause of iron deficiency anemia. This increased blood loss may be in the form of overt blood loss or occult blood loss. Overt blood loss is the large blood loss in the large amount, which usually occur during the trauma, in heavy menses, hematuria, and multiple blood donations. Then occult blood loss, which is the unnoticed blood loss, which is usually seen in the GI bleed and in the worm infestations. So what is pathology? Due to insufficient iron, there is decreased iron for the hemoglobin synthesis, lead to impaired erythropoiesis, and causes production of microcytic hypochromic erythrocyte due to insufficient iron for the synthesis of the hemoglobin. And this iron deficiency anemia is the most common cause of the anemia worldwide. So on the peripheral blood smear, how we know that there is abnormality in the RBCs? Usually we compare the size of the lymphocyte with the size of the RBCs. At normal condition, both have the equal size. But in case of the iron deficiency anemia, there is decrease in the size of the RBCs. Here we can easily appreciate that there is decrease in the size of the RBCs, and there is also increase in the central pallor region due to decrease the synthesis of the hemoglobin. And also there is the picarocytosis, variation in the shape of the RBCs. And here we can appreciate pencil cells. So what are the signs and symptoms of the iron deficiency anemia? First, signs and symptoms due to decreased oxygen to the tissues. These are the pallor, fatigue, activity intolerance, exertional dyspnea, palpitation, increased pulse, increased cardiac output, tachypnea, and pica, in which patient had desire to consume non-nutritive substances like ice and clay. And effect on the epithelial tissues. These are glossitis, in which tongue becomes smooth and beefy red, coliosis, in which there is a fissuring and dryness at the lip angle, cholynekia, in which nail becomes spoon shaped, and esophageal stricture and Palmer-Winson syndrome, which are the late complications. So how can we diagnose the iron deficiency anemia? First, on the CBC. On the CBC, there will be microcytic anemia, MCV less than 80 femtoliter, and there will be thrombocytosis, which is common finding seen in the chronic iron deficiency anemia, but it can be seen in the acute cases. Then on the iron profile, there will be decreased serum iron, increased total iron binding capacity, and decreased serum ferritin, which is the best indicator of iron deficiency anemia. And there will be decreased transferrin saturation, which is less than 15%.